Good afternoon and welcome to this first webinar of All.Can Belgium on survivorship. Today we will have a discussion with a very impressive panel, and I'm very pleased to welcome you our first guest, Marianne Bosman. Marianne, would you like to tell us something about yourself?
Yes, I'm Marianne Bosman. I'm a survivor. I'm 55 years old. I was in stage 4. I had metastasis in my lung, in my bone, in the soft tissue, and in the brains as well at the end. I had several treatments. I had targeted therapy, immunotherapy, radiation, and cognitive therapy. I am married. I've got 2 children of 23 and 25 years old. I have a language institute. I am member of the board of Melanoopunt. Melanoopunt is an association, a Belgian independent association for melanoma patients and their relatives. We want to gather the fellow sufferers. We want to inform them. We want to represent them and to support them in all aspects of their fight against this life-threatening disease.
Okay, thank you very much. Thank you. I will now present to you the rest of our panel. We start with Professor Awada, who is the head of the Department of Medical Oncology at Institut Jules Bordet, and he's also the chair of the board of All.Can Belgium. There's Professor Neyns, who is the head of the Department of Medical Oncology in the University Hospital of Brussels, and he's been involved for at least the last 20 years in clinical trials on melanoma and brain tumors, and also follow-up of outcomes for patients after immune therapy. We also have, thank you, we also have with us Régine Kiasuwa Mbengi. She is a scientist at the Cancer Center of Cienzano. And then we have with us, not in the studio, but via a video message, Dr. Françoise Meunier, who is member of the Belgian Royal Academy of Medicine and of the European Academy of Cancer Sciences, and she's an advocate for the right to be forgotten for cancer survivors. Unfortunately, due to unforeseen circumstances, Professor Rogiers could not be with us today, but I'm sure we will have an opportunity to talk with her later on her important work. So we will start with Professor Awada. Professor Awada, can you just briefly explain to us what is All.Can Belgium, and then also afterwards go to your work on the advancement in medicine for cancer and the impact on survivorship.
Thanks, Pia, for organizing this webinar. This was really very important webinar looking to survivorship. But let me start to explain a little bit what's mean All.Can Belgium. As mentioned here, All.Can Belgium is part of a big organization, multinational organization, international organization called All.Can International. So we are speaking here about All.Can Belgium, which involves many people and organizations, academicians, physicians from the oncology field, pharma, foundation, framework working for the management of cancer patients. So this is a really multi-stakeholders organization. If I would like to summarize in one word, the aim, the objective, the main objective of All.Can is really, I think the main objective is efficiency in the management of patients with cancer. And this is the reason why, for example, we are here to speak about this really important topic, which is the survivorship, which is an emerging and more than emerging topic in cancer. And as we see here in the slogan, adjusting to life with or after cancer. You know, I am in this field of medical oncology since at least now 30 years. My main expertise is in new drug development, so I witnessed the development of chemotherapeutic agent, hormonal therapy, targeted therapy, biological agent, with the development, with the understanding of the biology of cancer, and more recently, immunotherapy and modern immunotherapy. And Professor Neyns will explain a lot about this really important achievement the last few years. So, with all this development, as well with the multidisciplinary approach of cancer patient, I mean by that, the integration of all possibilities to manage patient, I mean by that surgery, radiation, medical oncology, new therapies, of course. Unfortunately, we improve a lot the management of our patients. So when I started my career, let's say overall, 40% of the patient, 40 to 50% at the maximum, are cured with this, let's say, therapeutic armamentarium. But now with the multidisciplinary approach and new therapies, fortunately, up to 70-75% of our patients are cured or with no evidence of cancer. And so, with this really major advanced in the management of our patient, there are several problems raised in our patient with cancer. Of course, we should manage our patient during the therapy, during the management. But now with really many patients cured from the disease, or let's say there are no evidence of cancer, there are a lot of issues raised in our patient, issues in relation to the medical follow-up, issue in relation to the psychological problems raised by the disease and the fear of the disease recurrence, social problem, financial problem, problem in relation to work. So this is what's called now today problem related to our patient who survive cancer or with no evidence of cancer. So I'm happy that we will discuss all this issue, and the aim now how to manage these problems optimally in order that the quality of life of our patient will be the best in the post, let's say, diagnosis and management of cancer.
Thank you very much, Professor Awada. You mentioned also immune therapy, so I will go to our expert on the subject, Professor Neyns.
Thank you very much, and thank you for having me here today, and indeed to discuss a bit more with regards to immunotherapy. And why immunotherapy? I think because it's been the latest big step forward in treating cancers. For about 10 years now, we have efficient immunotherapies at hand, and what we see is an emerging new population of cancer survivors, and that's why I'm happy to share some insights that we have gathered over the years now. But of course, immunotherapy, I think many of us are becoming familiar with the word, but I thought it may be of interest today to indeed perhaps give you some more insight. What does it mean, especially with respect to these therapies that we are now using much more common in our daily practice? So in order to comprehend this, let me illustrate by these slides that cancer cells derive from our normal cells. So by definition, they are derived from normal, but they are also characterized by differences. And these differences are related to the fact that cancer cells have defects in their genetic material. It's not inherited, or in most cases it isn't. The majority of these abnormalities, as for instance in skin cancers, are the consequence of carcinogenic effects of UV light. Consequently, they are derived from cells, but still different as well. And as any cell in the body, cells, they release parts of themselves. These parts, as illustrated by these small dots, these can be taken up. This is by physiological mechanisms, by so-called antigen-presenting cells. So the characteristics of these cancer cells are being processed and shown to our immune system, much like they would do in case of bacteria or viruses. And then effector cells, some call these the soldiers of our immune system. They can be triggered specifically, highly specific manner to recognize these new aberrant, new characteristics of the cancer cells. And when they find these presented at the surface, they will engage in an activity of killing off this abnormal cell. Now, in trying to do so, then these cancer cells can use mechanisms which are also proper to normal cells and say, oh, don't kill me because actually I'm part of yourself. And we have come to comprehend this. Of course, biology is still much more complex, but anyway, if you look at this cartoon, then you can start to comprehend why we have found ways to interfere with these mechanisms for the benefit of treating our cancer patients. And highlighted in yellow here in the center is a class of therapeutics that we refer to as anti-PD-1 or anti-PD-L1. And what does it stand for? It stands for therapeutics, which are monoclonal antibodies, big proteins, that interfere with these two molecules, one at the surface of the cancer cell, one at the immune cell. And if you use this, you can disrupt this interaction, and then the killing of the cancer cell can take place. So let me also take you a step back in time. Let's say not even 20 years, because what I'm showing here is what we call a Kaplan-Meier curve. What does it mean? So on the horizontal axis, you have time, and this goes out to 10 years. And on the vertical line, you have to imagine these would be a population of 100 patients. And the line actually tells you what is the chance that these patients are alive during time. And you can appreciate, and this is a cohort of patients that was treated on a trial not even 10 years ago. And they got chemotherapy. And look at this very poor outcome. This is melanoma that has metastasized to the organs. Less than half of the patients would survive 1 year after diagnosis, and less than 10% when you're at 5 years following the initiation of therapy. So at that time, as a patient being diagnosed with metastasis of melanoma meant all of a sudden you would be like in a labyrinth. And what the physician tries to do, what your doctor tries to do, there is no escape. This has changed. This has changed because of science. We have learned to comprehend what the immune system does and how we can even help the immune system to overcome this. At least for part of our population, this means cure, I dare to say, and I'll tell you why. Because we have learned from prospective trials, meaning that patients were indeed at a certain point randomized between old-fashioned chemotherapy and immunotherapy. And like 15 years ago, there was a first little step forward that we knew that a certain immunotherapy could help out a little percentage of the population. Today, the big step forward with these anti-PD-1, PD-L1 means that the curve now indicates that with current immunotherapies, 5 years out on treatment, half of the patient population will still be alive. Another curve I've drawn here on top of the immunotherapy relates to targeted therapy. There have been advances for sure in other fields, but the possibility to stay alive long term is better if you get the immunotherapies. At least for melanoma, this has been established. And moving from less than 50% at 1 year, we're now at 70%, and I already mentioned at 5 years, we have moved from less than 10 to almost 50% of the population alive. Perhaps even more important, or equally important, these curves do not indicate a possibility for survival. They indicate a possibility to stay without progression of the disease. So you go on therapy and you measure the time until the disease gets worse. And these curves indicate that unfortunately, we need to make progress. Why? Because 50% of our population, of our patients, will still have not enough to secure their future. They will be progressive, as we call it, so worse outcome within the first 6 months. But if you're doing well beyond 6 months on immunotherapy, look, your risk for becoming worse slows down over time. And as you move beyond 5 years, the line almost flattens. That means there will be no more risk for you to have a recurrence. And this can be achieved even when you stop therapy, and that's quite unique. Initially, the companies who developed this said, you can go as long as you want until the disease gets worse. one of them said, you can stop at 2 years, and you see that the curves are identical. So stopping at 2 years in those that do well did not make a difference. And again, this, if you look at the curves, if there is no more risk to have a recurrence, it could mean that you are cured. And we have most recently, like 3 weeks ago, shown institutional data reflecting on long-term follow-up. Now we have patients going out to 15 years. And on this curve, you can now appreciate that if you look at the curve beyond 5 years, it's completely flat. And what we've also shown that staying alive without progression, being cured of your melanoma, does expose you to other risks in life, just like you and me are also exposed to. And that's what we've shown most recently, that actually beyond 5 years, the risk for something else, a major health problem, becomes higher as compared to a recurrence of the melanoma. It puts it into perspective. It's not higher than for other people, but you know, it puts it into perspective that this is cure. And how long do you need to treat? Well, also on an academic effort, mainly done by one of my PhD students, we've come to appreciate that even 2 years is not necessarily needed. If you do very well, then probably more than 6 months to stay safe. We usually treat for 1 year, but if you're doing very well, you can stop and you have no higher risk to be meeting with progression. Another thing we've seen, and this was a bit, unexpected, is that people once being told that this is an incurable disease, and then now with newer treatment options such as immunotherapy going the distance, can struggle with this. And my wife, Professor Régine, who unfortunately could not join us today, has a psychiatrist really became interested in these problems. And she studied these, and we have a number of scientific reports. The research is still ongoing, but it highlights that, yes, there is specific care that we need to take for those issues because they can be solved. Perhaps not by the oncologist, because it's not chemo, it's not immunotherapy that solves these problems, but it's the care by physicians who are trained to deal with such problems. So with this, I think I've made my point. Thank you for offering me the time, and I think later on we'll have time for questions, right?
Definitely. That's good that you mention it, because I actually forgot to mention it at the beginning of the webinar also to our viewers, that there is a possibility to ask questions, and we will try to answer them during this webinar. I would like to turn to Marianne, because you can actually tell us a little bit of your experience with the therapy that Professor Neyns has spoken of.
Yeah. I have had immunotherapy as well. It's a very nice treatment, in fact. You are obliged to go to the hospital every three weeks. So you are strictly monitored. So, and it gave me a safe feeling. Mm-hmm. We had to stop after 1.5 years because I had too much edema in my head, and then I had some problems understanding people or finding the right words, mm-hmm. And then I was a bit desperate because I had already lost the confidence in my body, and now my head didn't function neither. So then my oncologist said, perhaps we can offer you cognitive therapy. Mm-hmm. And that was very nice because I saw that I was not the only one with that problem. Course, yes. And my problem was recognized by my oncologist, and I saw other people struggling with the same problems. Thing. So I gained self-confidence. We did mental exercises, etc. I had problems with my memory, with my concentration. Decision making was quite impossible, but I had the feeling that I progressed. And if you have a look at the test, because I had to make a test before joining the cognitive therapy. And if you compare it with the test after the cognitive therapy, I made a good progression. And last month, I had the opportunity to join a study in which they did the same test or the same sort of test. And then you can see that I even progressed more. So in fact, I needed the cognitive therapy to get a boost, to get a push in my back, and I could go on myself. So that was really a very big help.
Yes, I can imagine.
Yeah.
And that's exactly what you say as well, that it's not just about the medical treatment. You know, there's, like Marianne says, there's the body and the mind, and it's important
It's
to...
one.
Yes, yes, definitely. There's a lot of issues with in survivorship. We discussed medical, you know, you talk about the cognitive function. There's other problems that patients face as well after cancer treatment. And then we talk about the financial issues, for example. And we have, unfortunately not with us, but via video message, Dr. Meunier, who's become an expert in this matter and who will talk to us via video message on this important topic as well.
First and foremost, I would like to thank the Planning Committee of All.Can for organizing such event. I am extremely delighted to share my experience and to speak about the importance of putting an end to the discrimination for cancer survivors, a topic very close to my heart since 2014. My name is Françoise Meunier. I am a Belgian medical oncologist, and since the last 45 years, throughout my professional career, I dedicated my life to the improvement of patient survival and quality of life by defining optimal treatment for those patients. But I also witnessed tremendous challenges faced by cancer survivors once medical doctors tell them that they are cured, and particularly what we call the financial toxicity, meaning difficulties and challenge to get loan, mortgage, and insurance. Already as head of the European Organization for Research and Treatment of Cancer, EORTC, I created and organized 3 cancer survivorship summits to increase the awareness of the problem faced by cancer survivors in relation to insurance and mortgage mainly. On several occasions, I suggested the creation of an European Cancer Survivor Day, an annual event to raise the issue of survivorship and difficulties that patients face to get back to normalcy. In fact, what does it mean, discrimination against cancer survivors? Cancer survivors are no longer cancer patients undergoing treatment, and we have to distinguish the phase between the diagnosis and the 5-year period where the doctor tells to the patient, we no longer need so much follow-up and test, go back to your normal life and enjoy the life. Cancer is no longer a death sentence. At that time, the many cancer survivors faced financial discrimination, and ending this discrimination can change the life of millions of European citizens. The number of cancer survivors increased every year, and today there are 20 million EU citizens in such category, including 300,000 Belgian citizens. This represents a tremendous increase of 45% of survivors between 2010 and 2020, and this is thanks to the tremendous progress and work of research involved in developing optimal treatment for numerous cancers. So far, 6 European countries have established a legal framework to end the financial discrimination of cancer survivors. And as a Belgian, I am extremely proud to say and to witness the fact that we are the second country after the pioneer work of the France, which initiated the way in 2016. Belgium followed in 2018 with the legal framework on the right to be forgotten. What does it mean? It means that currently, 10 years after the end of treatment without any relapse, insurers can no longer penalize and discriminate either by refusing to get a loan and a mortgage on an insurance or by increasing dramatically the premium. And there is now a lot of proposal to reduce this delay of 10 years to 5 years, taking into account that in France, indeed, in February 2022, the delay has been decreased from 10 years to 5 years without any prejudice for insurance company. And in Belgium again, KCE has published a report specific on breast cancer, showing that for many small breast cancer, what we call in situ, the delay should even be much shorter than 5 years. And I like to mention that for many cancers with better prognosis, there is a list of exceptions decreasing the delay of waiting for getting an insurance. And this list is regular update either annually in France or biannually in Belgium, with a lot of cancer which significantly benefit from a shorter delay than the current official 10 years delay. This list of exceptions is really important and is increasing with the progress made on the survivor of patient. In addition, in Belgium, we have what we call a Bureau de Suivi, which is an excellent initiative, which is supposed to analyze and get feedback from patients to whom the insurer has either refused the insurance or request tremendous high premium compared to a premium for a person not affected by cancer. This is also a very good initiative, and we have to acknowledge that. Now, on the EU level, as I said, there are only 6 out of the 27 countries who have this right to be forgot implement in legal, in national legislation. And we are on a good way for the other EU countries because the Commission has endorsed the concept and the right to be forgotten as mentioned in both the Beating Cancer Plan and in the Cancer Mission recommendation. So those are really important steps towards a right to be forgotten and ending discrimination for all EU cancer survivors. In addition, at the European Parliament, they are currently revising the Consumer Credit Directive with amendment which should pass in October 2022 and acknowledging the fact that the cancer survivor should no longer be penalized. So this is an extra step that we are looking forward. I am ready to continue advocating for the necessary change for cancer survivors in order to end discrimination and financial toxicity. And I thank you for your attention and for a fruitful debate. Thank you.
Thank you to Dr. Meunier for this very important message. It's clear that there's still a lot of work to be done for patients after cancer. Professor Neyns and Professor Awada have given us a lot of hope in the advancements on therapy, but it's clear that we need still a lot of work to do. And then I come to Régine, who will explain to us what are the needs, the priorities to implement survivorship in Belgium.
Yes, thank you, Pia. Indeed, there are a lot of issues when coming to the quality of life of cancer survivors. Marianne explained her experience of cognitive impairment after her treatment. There are a lot of different symptoms and side effects of treatment that need to be taken into account and to be provided. And the access to this care should be ensured for all cancer patients. And unfortunately, at the moment in Belgium, is not the case. So the system is a bit lacking behind the technical and medical advancement. And we have the chance to have very good clinicians who strike for saving lives, and they do. And we see that the numbers that are increasing, that the period of treatment are shortened, and so on. So the system has to follow these improvements and also foresee the care for the survivors. And so in the last year, we worked a lot at the Cancer Center of Cienzano on this issue, trying to identify the needs, both of the patient and the professional, but also of the system. What does the system need to actually implement this care, and what are the barriers for the implementation? And there are several of them. So in the framework of the Belgian Cancer Barometer that has been organized by the Foundation Against Cancer, we closely work with the Collège Oncologie, the Belgian Cancer Registry, to actually organize a comprehensive overview, both epidemiological and political state of play, actually, of the situation of the cancer continuum in Belgium and cancer control in Belgium. And we also, based on this state of play, identify some priorities. Today I will focus on one of the chapters of this report, which is the chapter on survivorship. So regarding the main priorities that we have identified, and this is only some of them because there are plenty, but I want to focus on some of them that I think that are the most urgent today. First, we identify a lot of inequities organized, unfortunately, coming from the system, how the system is organized. And these inequities also are found, for example, in the type of care that can be provided by the different centers. It's not equal. Not all patients receive the same attention for all the symptoms. So I think that how we could manage and how we can decrease these inequities is certainly in the development of a minimum set of care for cancer survivors to ensure that at least their symptoms are taken into account and improved. We also identify a lot of inequalities. So among the difference of the patient because of the type of cancer, because of the social economic position, because of their own possibility and ability to look for help, there is a lot of difference among the patient. And this is really not acceptable. All the patients, whatever the socioeconomic situation social economic situation is, they should be cared equally. And so a way of answering this issue could be to implement in all cancer centers a need assessment and a screening of the need to ensure that the demand is not coming from the patient, but that the professional identify these needs and can proactively go to the patient with some solutions. Another important point is in survivorship care is the gaps in the knowledge. We know from the literature that there are a lot of interventions going on, but we don't have sufficient evidence, unfortunately, to propose a survivorship care plan that would be acceptable for the government, for example, the social security system, because we lack some evidence. And so I think, although these interventions they do exist, We heard Marianne that received this cognitive therapy. So a lot of intervention do exist in all the domain to treat all the symptoms. But what we need now is to test a bit these interventions and to see to which extent they can be adapted and integrated in the care. And how they can be organized. And this type of pilot, we can call it health services research, for example, and more epidemiological kind of work can generate some evidence that, okay, this work, this can be implemented, this can be also cost effective. That's a very important aspect also of these issues, is to also show the cost effectiveness, especially on the long term. If we treat patients, then the quality of life improve, but also the burden on the social security system and the healthcare system decrease. That's a very important message. And last but not least, the access to quality supportive care. It's true that it's a bit, again, linked to the gaps in the knowledge and the differences among the patients. So not all patients, all cancer survivors need all type of support. So also that's also an important message, I think, for the decision makers and the policy maker, is that they should not see a supportive care as an additional burden in terms of cost on the social security system, but as really an added value for the quality of life and for the system. And the fact that not all patients need all type of cares, I think it's really an important message also to be given. It's also we also need more expertise to be available for cancer patients. So all these symptoms can be treated by different approach. We have the physiotherapists, ergotherapists, psychologists, dietitians. I mean, there's a plenty of professionals that can help, who can help, but they also need some expertise with oncological patients. And so they need training, they need to be trained, and their training need to be recognized, their expertise need to be recognized, also as an incentive for training, for the professional themselves, but also to reassure the patient and the professional that they can refer their patient to quality supportive care. So it's very important to also ensure the quality of the care by ensuring that all these professionals are well trained. And so I will stop here for today, but I would be happy to answer all the questions today or later on. Thank you.
Thank you very much, Régine. And I'll just remind again the viewers that it is possible to ask us questions, but I already have a question for you, Régine, on what you just explained, because you were talking about a gap in knowledge. And maybe this question can also be put to Professor Awada, Professor Neyns. What type of research, for example, do we need then to fill this gap that there is?
So I mentioned already health services research, which is actually piloting some intervention to see how they can be adapted and integrated in the care as it is organized now in Belgium. There are also some more specific topics that require some more investigation, such as the comorbidities. It's not always easy to actually support a patient who develop or who already have some disease before cancer. And so the interplay between all this treatment and also the impact of all this treatment on the patient still need to be investigated. So I think also that comorbidities is an important question, especially for elderly, but not only.
Okay, thank you. Professor Awada, do you have any view on that? Yes.
Sure, I think Régine mentioned really one important topic. She used the term screening and assessment. Mm-hmm. You know, we have the habit to speak about screening of cancer. Here we are screening of the problem related to the treatment and the post-treatment in our cancer patient. I think what's really important, and Marianne mentioned one sentence, my problems, my problem. And that's mean for each patient there will be a specific problem. That's really important at the end of the treatment, in the first months of the treatment, that one person could be a coach, and I can tell you we have a project on that will sit with the patient and to see what will be the problem in this patient, because I am sure we are speaking about precision oncology, precision treatment, and there we should be more precise, personalized approach to ask the patient what are your problems, and to try to define the problem in this patient. And secondly, we will do all possible at the multidisciplinary level, because there are no one people who could solve all the problem of the patient. It would be multidisciplinary approach. And a third thing is really important, will not be a one-shot intervention, should be a continuum, because possibly we'll look to one problem and 2 months later there will be another problem. So this is a long life intervention. And so in order to do all the things, we should put all the infrastructure needed for that. So only to summarize very quickly, in my department and our institution, we launched a project called, is a very nice Printemps project. So we have a coach at the end of the treatment and the beginning, let's say, of first 3 months after the end of the treatment. So one person will sit with the patient, define the problem, and we try to help the patient to solve at least some of this problem, because there are problems related to the doctor, related to the institution, to discipline, but also there are a problem like financial toxicity that will be discussed at the other levels. And finally, I think research is still important even in this field, because it's important if we go to intervention to evaluate what was the impact at the end. And that should be done in a specific project, well defined from the beginning. We need one where to arrive, and eventually here the patient, if I could say things like that, would be its own control.
Mm-hmm. Professor Neyns, do you have any reflection on what Régine said, or just what we've been discussing?
I think I would like to echo what has been said, and definitely so that the needs can vary with over time, right? So we need to be aware that issues that come, for instance, at an important point in time can relate to the fact that active therapy will be stopped. And that may seem a bit odd, but I understood also that you mentioned that while you're on therapy, it also gives a kind of reassurance that you're well followed up. At a point sometimes can be surprising, but when cancer patients finish their therapy and all of a sudden, you're told it's okay and now you can disappear and only come back like in 6 months for your control, it can be a moment of anxiety, and I think we need to be aware. This will fade out over time in most of the patients, so it needs to be timely, the kind of screening for issues. We have to bear this in mind. Another point that I can touch upon is that indeed we need to be aware that the medical oncologist, of course, will be there and needs to be aware of issues and try to have a feel for being receptive if patients have issues beyond the cancer itself, psycho-emotional issues. But still, and that's something that came forward out of the research my wife did actually, is that I'll try to bring this under words, but it relates to the fact that a patient can be really happy meeting with the oncologist, being told that your scan is fine, the tumor has gone, you're doing well on a medical level, but at that point in time, it's difficult sometimes to also say, but on an emotional level, I'm not okay, because much like we all are dealing with, we are under pressure with respect to having time, and beyond having the time for our patients, which needs to be dedicated, and that's our first role, treating the tumor, there may also be from the patient some issues with sharing these problems, while at that point they are really happy. But when they see afterwards somebody else, there is room and time to deal with the other issues. We have to be aware of that. And so having somebody to screen for those issues beyond the consultation with the medical oncologist, that's important, I think.
Yes.
Yeah, if I could add something here. I think the general practitioner play also a role in the management of this problem, at least in the diagnosis, and eventually orienting the patient to the multidisciplinary team, because Of course, the medical oncologist has a role, following the tumor, following the screening the problem. But I think general practitioner should be familiar, educated to some extent, to take in charge also this problem. And in my opinion, I think they will play a major role also in the management, mainly with really long life story.
Yes.
And I think there's also of importance that we educate
Yes.
the general practitioners, also with respect to survivorship and the new possibilities that emerge with our newer therapies, because that's also a challenge. We know it's becoming quite diverse. There's a lot of new information, and it's not what they have learned at university that will be applicable today. So we need kind of continuing education as well for these colleagues.
Yes. And I think, Régine, you mentioned that as well, about the expertise,
Yes.
the need to recognize this expertise.
Yes, it's very important because often the health professional want to specialize, but first it's difficult to organize it in practice, so they need also to be supported by the structure where they work, and also they need to know that at the end they would be recognized for this expertise, and so they can also offer the proper care to the patient in this area. I think if I may just also add something about research. I think we are going more and more to personalized medicine and so personalized treatment. And I think that in terms of survivorship, it also play a role to have personalized pathways for survivors. Not all cancer survivors, I mentioned, need all type of care. So I think that these after having screened and identified the needs, we can organize a plan that is really individual. And I think it's very important to go also through that way, but it would also require some information about which aspect can be personalized within the system. And this requires another type of research, I would say, which is more qualitative type of research to understand which step of the survivorship pathway can be individualized and what it does require. So it is also important to invest in more qualitative type of research to better understand the differences among the patient leading to different needs.
Professor Awada.
Yeah, I think Régine is right, because take the pediatric are not adult patient, cancer patient. Young patient, I mean between 18 and 25, high school, university, the problem there are different from the people 30, 35, 40, 45, active work, active professional situation is not the same than elderly patient more than 70 years old. And so the individualization is really at all level. And so surely there are common problems for all these categories, but there are specific problems related to each period even of time.
Yes, definitely. And we were talking about cognitive issues. Most patients can also recognize it, whatever the age, but the impact on their life is different. If they have to go to school and focus, if they are working, if there are parents who have to take care, if they are elderly. So I think that it does then require different type of intervention and treatment. So all these aspects need to be really carefully thought in advance.
I think to be also complete, I think there are the patient, but there are the family. And it's important and also to see how to manage this, let's say, ensemble, as we say in France, because this is really, in order to be efficient, because we are speaking about All.Can and the role of All.Can to be efficient, so we cannot only take the patient as the patient, but the patient and the environment. And of course, the environment means family and friends, for example.
Yes, and Marianne, you spoke about that as well, huh?
Yeah. I think it's really a very personal problem, and as well, the patient must want to be helped, because it's very difficult when you have been cured of cancer. It's difficult to say yes, but I'm not feeling well. Je suis pas bien dans ma peau. It's not great. You're not grateful if you say to your oncologist or to whomever, yes, I have been cured, but what now?
Yes, we spoke
So-
about that. Huh?
The patient must be incited to talk. It's not evident that he will talk about his problems.
Yes.
That's difficult. That's a difficult step.
And you spoke about when we spoke together, about the trust you need to have also in your doctor
Yes.
to be able to
I think
take that
the
step.
relationship is very, very important. It's a relation of trusts. I think it's very important to tell your oncologist everything, all the side effect that you feel, the way you feel yourself. The more you give information to your oncologist, the better he can react on your problems. But not everyone does that. And that's also why Melanoompunt can help, because we can insist as well on the fact that it's very important to have a nice, open relationship with the person who is treating you. Because if you don't tell everything, the other person cannot help you as needed.
Sure, and then we also get to this point that we discussed earlier about the screening, because then it's easier for a patient maybe who does not talk easily about other problems, but if you have some kind of screening tool, then at least the problem will be discussed, if not in the office of your oncologist, at a different point. Yes, thank you very much. I would like to just see together if you have a final message, each of you, to summarize what we have said, or maybe some point of attention that we can give to the viewers as well. And I'll start with Professor Awada.
I think that there will be no one person, one foundation, one organization, let's say the ministry, the Sansano. I think this is really a work of all these persons and organization. I think we should work together in order to advance in this, in order to relieve many of the problems related to cancer patient in the post-treatment. So this we are at the beginning. We have a long way to achieve our objective, but I think that's really important. And this webinar, the aim of this webinar organized by All.Can Belgium is really important to sensibilize all people able to help. And I would like to thank Professor Meunier, for example, for really her intervention since now 2014 for this really important question, financial question, because it's really important in order to stabilize the social life of our patient.
Yes. Régine.
Yes, I fully agree with what Professor Awada just mentioned. I think it's really a core business of the whole society, actually. And we discuss about the training of GPs, for example, and also the awareness of different professionals. I think that the society has to be aware of the side effects, the symptoms, to also better integrate the cancer patient and to better understand their situation. Some of these symptoms or side effects can appear later in the trajectory and can surprise a bit the patient himself, but also his family, and also, for example, the colleagues at the office who can maybe not understand the situation of their colleague who suddenly doesn't feel well, but the treatment is already ended. So it can be a bit confusing for all the people. So I think that, yeah, it's really a work of raising awareness on survivorship issues in the whole domain and in the society in general is very important.
Thank you, Régine. Professor Neyns.
So maybe that preparing the future, we should also try to make, to some extent, a mentality change, by which I mean that of course, we as physicians, perhaps most, can be traumatized by the horror of advanced disease and still losing way too many patients from cancer. On the other hand, if we don't embrace survivorship, we'll also be leaving behind too many patients now who do make it, and they need to be considered as heroes, having fought a disease and having become survivors. And we have to approach this more often in a much more positive way, I think, because otherwise we'll be having a large number of patients out there that are stigmatized, and that's not to the benefit neither for those patients and not for society. So we have to make that step forward.
Definitely. And I like that word, heroes, very much.
They're my heroes.
Yes, and we'll go now to the hero of this panel and give you the final...
Yeah. When your body is cured from cancer, perhaps your mind is not cured yet. You have had years of an emotional roller coaster. It's normal that your mind is affected as well. So why shouldn't we check before we release the patients in the wild nature again? Why won't we verify if the mind is okay as well? I think it would be very, very beneficial for the patient.
Definitely. And you said it also, survivorship is a second chance?
It's a second chance,
yes.
Yeah. Don't look back, just go for it and embrace life.
Definitely. That's a really, really nice message to conclude this webinar. Thank you very much to this excellent panel. Thank you to the viewers. I would like to also remind you that this webinar has been registered, so there's a chance to review it later. We will put it on our YouTube channel. And if you have any feedback, because we talk about efficiency in All.Can Belgium, we also need to make sure that we are efficient. So give us any feedback that you have after this webinar, and I leave the last word to the chair of the board of All.Can Belgium, Professor Awada.
Thanks, Pia. I think that's really, we discussed today about survivorship. I think it's important to mention, even if we extend a little bit the discussion, that All.Can Belgium is involved in many other projects. I would like very quickly to mention some of them because it's really important for next webinar. We are really supporting a very nice project from UZ Brussels and UZ Ghent, which looking to how the patient could be more involved in the what's called shared decision making, the COM, the MOC, in cancer management. We are also endorsing a very important project really is ongoing now in order that in young patients that the diagnosis of cancer, breast cancer, testicular cancer and sarcoma will be diagnosed much more early than current. And third, there are also an important project which is in preparation in order how to be efficient more in clinical research. And that's really my last word. And this is also the last word. I would like to thank Dr. Cox, Pia, for organizing this webinar. I know that, of course, we are spending here 1 hour, but this 1 hour was really take hours from your side to prepare to in order to be also efficient during this webinar. Thanks, Pia.
Thank you very much, Professor Awada. Before we close, there is one more question that has come in that we do have a little bit of time left that I would like to see if we can answer it, and if not, we will answer it later on. Do you consider digital technology for remote monitoring of cancer patients as a way to improve their quality of life? This is a very big question, but maybe somebody has a quick view on that, and then we can take it maybe to a next webinar.
Yeah, I think if I may try to answer, it's a hot topic, I have to say, digitalization, and certainly in the monitoring. It has pros and cons, of course. It has to solve a lot of not only technical but also ethical issue and the protection of privacy and so on. But there are a lot of projects, especially at the European level, for developing some app to allow the monitoring, linking also the result of this monitoring into a clinical setting to ensure that if something come up, that the clinicians are aware of and can contact then the patient. So I think clearly in the future we will see such kind of tool coming on, but yeah, it will take some time, but I'm sure that's also the direction we're going to.
Thank you very much, Régine. You see, we can keep on talking about this very important subject, but we will leave you for now. Thank you for your attention, and we will definitely see you next time.